Greetings, everyone. Welcome to the 98th session of the online Optom Learning series. And today we have a very senior optometrist. I think people in India I think if they don't know Yeshwant sir, they are missing out on any contact lens related complications, but contact lens related education particularly. So, but for the interest of our international attendees, today we have Yeshwant sir, Yashwant Saoji is a senior optometrist from Nagpur, and he specializes in the field of contact lenses. He has a vast experience in clinical practice of about 29 years now. He holds a master's degree in optometry from the School of Optometry, Bharatiya Vidyapith, Pune. He is a graduate of the Elite School of Optometry, Shankar Netralaya, Chennai. He then pursued his fellowship at the LV Prasad Eye Institute, Hyderabad. I think it was the first batch in the year 1992, right? And actively associated with contact lens education in India and has been awarded lifetime accreditation as the fellow of the International Association of Contact Lens Educators. And this is a very prestigious title, I would say, because you need to maintain the fellowship title continuously for 15 years. And with that experience, they award you as the lifetime FIACL status. So I think that's commendable. And I think sir has been in the first few Indians who got this title, if I'm not mistaken, sir.
I think I was 11th.
11, yes. So yeah. Again, that's a very commendable efforts in the field of contact lens education. He was also a senior faculty for contact lenses at the BVP School of Optometry in Pune for about 8 years. And now he is actively involved in practitioner education programs. He is also the senior faculty at the Vision Care Institute of Johnson & Johnson, India, and also a key opinion leader for Bausch & Lomb and Alcon. With all this experience, definitely he has several awards to his credit. He was awarded the Best Optometrist of the Year 2011 by Shankara Netralaya, Chennai, the Living Legend by Optometry Students Association of AIMS, as the BIPOC Ambassador for working towards myopia control awareness in India. His areas of expertise are contact lenses in complicated corneas, specialty contact lenses, including ortho-K and myopia control. And correct me if I'm wrong, sir, your practice, Saoji Vision Care, was awarded as one of the best or one of the first few centers to develop myopia control in India, right?
No, actually this award was given by David Thomas Contact Lenses UK for fitting irregular corneas and keratoconus patients. So it was awarded as first center of excellence. And I think the certificate should be here somewhere. If you can see just behind my head. That's the certificate.
I can see that. So yes, so it was for irregular corneas. Yes, that's right.
That's right. Yes.
So, I mean, all this, why I'm emphasizing in all this, because of the experience sir has, and with that experience, he's very helpful to take a session for us. And with all this love of education, teaching people across, he, with one of the very famous Indian optometrists again, Nilesh Tite, have co-founded Masterclass Optometry. And the intention of Masterclass Optometry was to make a difference in optometric education in India, where, Masterclass Optometry not only conducts seminars, conferences, but they also do a lot of programs, training camps, boot camps for ortho-K, contact lens fittings and all that for practitioners as well as students. And very recently, he has also been voted as the alumnus for the year 2021 by the Association of LV Prasad Optometrists. So with all that credits and all that knowledge, experience, today sir is going to talk to us about how can we fit RGP contact lenses, specifically try to share with us some fitting pearls and perks. So welcome Yeshwant sir onto our platform, and let me just leave the screen time to you.
Thank you, Fakhruddin. Good morning, all. Good morning, all who are joining from Malaysia as well as from India. It's a Sunday morning, and I really feel honored that so many people are joining the session. And Fakhruddin, I'm happy with the polls that students are showing so much interest in RGP contact lens fitting. And clinical optometrists also, people who've not yet started RGP contact lens fitting, it is high time they need to start. Here I am today talking about RGP contact lenses. And some of you would know that today's session is the 98th session by Fakhruddin's association. And practically all the specialty topics have been covered. So I thought, why not let's discuss basic contact lenses, the RGP contact lenses. It's always nice to revise RGP contact lens fitting pearls, right? So the lecture would serve as a revision lecture and not as the one that teaches you RGP contact lens fitting. But I'm sure if you pay attention to the slides, you would get a lot of helpful hints which will help you in fitting of RGP contact lenses. So let's begin. About 10 years back, people used to say RGP contact lenses are going to die soon because of the advancements that were taking place in the field of soft contact lenses, the materials, the lens design, the machining, and so on and so forth. That many people felt that that's the end of RGP contact lenses. And there are few loyal RGP practitioners in India, and I'm one of them. And we always loved RGP and we continue to love RGP. So they are not dead yet, and they have made a comeback, and this time they are here to stay permanently. Why? Because yes, there is a definite need for RGP contact lens. And mind you, when I say RGP contact lenses, I'm not saying I'm not limiting myself to the RGP corneal contact lenses, but it includes your ortho K, your myopia control, your scleral contact lenses, miniscleral lenses, bitorics. So all these are rigid gas permeable lenses, and they are safe. We all agree, and especially people who routinely fit RGP contact lens definitely would vouch for it that they are safer than any other contact lens, and they're easy to maintain and relatively more economical. We have a wide range of materials available. In fact, we are spoiled for choices. There are so many materials, and it helps you to become a specialty contact lens practitioner, and it places your practice at a higher pedestal as compared to your nearest competitor. So these are great practice builder contact lenses. And mind you, because of these lenses, only Fakhruddin has invited me today to be present on this forum, right? So RGPs are here to stay. They are back. And that's the famous dialogue from Arnold Schwarzenegger, I am back. So we all know why we need RGP contact lenses in our contact lens fitting arsenal because of many compromised corneas, irregular corneas, and these are the only lenses that offer crisp vision because they don't flex with the curvature, changing curvatures of the cornea. So the crisp vision is an endpoint that you want for your patients and the patients also want from you. And they are almost available in all the parameters. So you talk about torics, you talk about peripheral toricity, you talk about bitorics, then orthokeratology, myopia control, multifocals with torics, everything is available. Zero online sales. So for people who are bothered about their online sales, their contact lens practice getting affected because of online sales, if you have RGP contact lens practice, then there is zero threat from online and practically zero competition. Even if your fellow optometrist is fitting RGP contact lens, still there is no competition because my fitting is going to be different, that person's fitting is going to be different. So a person who's happy with my fellow optometrist may not come to me, and the person who's happy with my practice or my fitting of lenses may not go to him. So practically we have a patient for life. And great earnings, both professional satisfaction wise and monetary wise, although primarily we are not here for the money, but money forms an important aspect of our contact lens practice. So both ways you get satisfied and excellent patient satisfaction. In fact, people would often fall down at your feet when they're able to read 6/6 from virtually nothing. So it's an amazing visual recovery with RGP contact lenses. It's a win-win situation for both the optometrist and the patient. In spite of all these obvious advantages of RGP contact lenses, there are many who still don't get into fitting of these lenses. And the possible reasons could be lack of knowledge and expertise. Personally, I feel that's the most important reason why people are intimidated by RGP contact lens fitting. And personally, again, I feel that communication forms a very important aspect of your RGP contact lens practice. It is how you present the RGP contact lenses to your patients. It's not as easy as a soft contact lens. You have to talk about the advantages and slightly tone down the disadvantages. The disadvantages are only there in the initial phases, maybe a 1 week adaptation period. But once the patient sails through that, then the patient is going to love the RGP contact lenses. So here's the solution for people who've logged in. They understand the importance of learning RGP contact lens basics, and that is why on a Sunday morning they've logged in. Thank you so much again. Be an observer. Go to a practice who routinely fits RGP contact lenses and observe maybe 10, 15 patients of RGP contact lenses. And that should be enough to get you confidence to at least begin. And how do you begin? You attempt easy cases. Maybe you attempt these cases on your friends and relatives, work out a deal with your contact lens lab, and they can give you lenses in PMMA or low decay materials, which are very economical. Try them on all your known patients and gain expertise. Remember, I said counseling is a very important aspect of your RGP contact lens practice. So if we need to explain the condition to the patient, and for that you can have high-tech gadgets like your iPads or tabs, and using animations you can explain to the patient, or as I prefer, I prefer pen and paper. So what I've seen is when you draw the cornea and when you draw the tear lens and the contact lens, the patients are more attentive. The moment you take a pen and paper, instinctively everyone directs their gaze at the pen and paper. So for every patient, I use a fresh paper, and sometimes I use gestures of hands to explain to the patient. This gets them attracted, and they understand why a soft contact lens will not work in their case and why we need a rigid contact lens. Uh, Show them the lenses. So if it's a keratoconus case, then I show them that this is the corneal RGP and this one is the scleral contact lens. These are the advantages of corneal and these are the advantages of sclerals. But finally, it is I who gets to decide whether I should prescribe a corneal lens or a scleral lens or a toric corneal lens or a toric scleral lens. And sound positive. So I have seen that frequently we make mistakes. Even I do it at times, and especially to the students, we make this mistake of telling the patients, this is a rigid lens, so this is going to hurt you a bit initially, and the eyes might water and they might go red. Now imagine saying this to a patient who is going to wear this lens in another minute or so. If I was the patient, I would say, I'm not interested. Thank you so much. So you, rather than all saying all this, you concentrate on the positives, tell them that this lens is going to be comfortable very soon, and it will help you to see the world so clearly. And it's not about the clear vision alone. It's about your binocular vision. So you tell them that when you wear these lenses, you will get depth perception and the chances of you falling down the stairs are greatly reduced. You can drive more safely on the roads. So when you talk about these obvious advantages, they are more inclined to try these lenses out. And I often quote examples like ring on your finger. If the person is wearing a ring, I tell them that remember the day when you wore this ring for the first time. You would have removed it 10 times in the day. I've done it. I used to wear a ring earlier and I would remove it every now and then. But once you get used to it, you don't even realize that you're wearing a ring. So if it's a girl patient and you know the earrings, or you can give example of a watch, or you can talk about bicycle. You did not learn bicycle riding on day one, so it's a process. You might take 3 or 4 days to get the balance. Similarly, you need to get adapted to the RGP contact lenses, and eventually you're going to enjoy the benefits of these lenses. So optical indications, we all know toric corneas. So sometimes these patients would need toric lenses or bitoric lenses, and irregular and post-graft corneas and multifocals, especially toric multifocals, because at least in India, we don't have a toric multifocal contact lens in soft material for presbyopic patients. And orthokeratology and myopia control contact lenses, and sometimes therapeutic scleral lenses are given to patients like chemical burns, Steven Johnson syndrome, and extreme dry eyes, other than irregular corneas. So one of the tips that I would like to share is you know and you understand your trial sets thoroughly, right? Obviously, we know that there are different trial sets for normal people and different trial sets for compromised cornea. So if it's a keratoconus patient, your regular contact lens trial set will not work for these patients because we know from center to periphery, the rate of flattening of the cornea is quite high. So you need lenses for keratoconus patients which are steep in the center and which rapidly flattens in the periphery. So don't ever make the mistake of having the same set for normal corneas and keratoconus corneas, right? Understand the lens designs very well. So now this is a very tricky part because you need to win the confidence of your lab because not all the labs would like to share their trade secrets. But if you understand what is the first curve like, if you're talking about the corneal RGPs, how flat do they go on the first curve and then how much flatter on the second curve and third curve, and what is the edge lift like? So if you understand these curves, then it becomes easy for us to modify these curves without understanding just by looking at the fluorescein patterns. It's a shot in the dark. Material availability, practically all the labs have all good materials, high decay materials. You have the choice of branded materials. I would leave it to you and the lab. Uh, Often I do this. If it is going to be a complicated case, I do all my calculations, conduct a trial, and I come to a conclusion that this is the lens that I would like to order. But I'm not 100% sure because it's a complicated case. So rather than ordering in a high decay material right away, you can order the lens in PMM or a low decay material, which I told you are very economical. Try the fit on, and if the fit is satisfactory, if the vision is good, duplicate that lens design in a high gas permeable lens. Uh, Keep verifying the parameters in the trial sets. Like I've got a huge inventory of trial set. I think I've got about 15 or maybe more than 15 trial sets. Now, if there is a mix up, then your trial goes haywire. And this happened with me about 2 months back. We ordered a lens based on the trial, and the lens was completely off the expected fitting parameters. And we did not understand where the mistake was until we realized that we had swapped the trial lenses, and my whole trial went haywire, and we lost a lot of money in that. So make sure you verify the lens parameters often, and if it's a mark set, if the parameters are mentioned on the trial lens, then it's the best thing. Then it becomes very easy to maintain your trial set properly and keep it clean, especially in these COVID times. It is very, very important. We have, I'm underlining the word have, to use fluorescein when we are fitting RGP contact lenses. I've seen a lot of senior practitioners and very well-known practitioners who avoid using fluorescein and just go by the movement and slit lamp examination. No, that is not the right way, because sometimes you have to see fluorescein to an extent of 30 microns or 40 microns or 50 microns. And although fluorescein can give you a decent idea, but I mean, although slit lamp can give you a decent idea, if you use fluorescein, then your job becomes so much more easier and it becomes more accurate. So this used to be my favorite question when I was teaching students. When we throw cobalt blue light, why the fluorescein pictures are in green? And very few people could actually answer this question, because today we all know that it's the yellow rattan filter. So one is the exciter filter and the yellow rattan filter is the barrier filter. So it gives us more accurate understanding of the fluorescein pattern. So if you're an RGP practice, make sure you have the rattan filter. uh, Earlier days, when I was a student or I had just graduated, we used to draw the fluorescein pattern using color pencils. Like I remember my LV Prasad days, we always had a pen stand having so many color pencils, and we had to draw the corneal edema, neovascularization, fluorescein, and all that. But today we have the advantages of image capture. I have an imaging system with me. So the bottom picture that you're seeing is captured on the imaging system, so we can store these pictures for ready references at a later date. And understand the various fitting philosophies, like we have the lid attachment technique or the corp technique of fitting the corneal RGPs, or you've got the 3-point touch fitting philosophy in a keratoconus fit, or the bullseye pattern in the ortho K fit. So you should be familiar with all these terms and understand what they actually mean. This is very, very important. So you've seen the fitting on the cornea, but you should understand how to modify the fit. So understanding all the parameters and how they alter the fit, if you want to keep the fit same but reduce the diameter, what should be done? We'll cover that in the subsequent slides. If the lens is rocking too much or moving too much, excuse me, what needs to be done? So let's understand fitting protocol. It's quite simple. Patient selection. So you know this patient is suitable for a rigid material and not for unsuitable for a soft contact lens material, soft contact lens. So patient selection and counseling is very crucial. One of the key things that I would like to observe here is I would not proceed with the trial until and unless the patient himself or herself is ready for the trial. Frequently, I've seen, the patient is not willing, but the parents are more than willing to fit contact lenses to the patient. And that happens frequently in India, especially for marriage reasons, and sadly so. So, my rule is until and unless the person who's going to wear the contact lens, if they are ready, I proceed with the trial or I keep on counseling till they become ready. Pre-fitting evaluation, which includes your HVIDs, VVIDs, tear function tests, your keratometry, your corneal topography, slit lamp examination. So all that you have to do and document, because this helps you to decide what material, what kind of lens design, what should be the diameter of the lens, what should be the curvature of the base curve. Then finally, based on these, when you get a first trial lens, you put the lens in the patient's eye, then you conduct a complete trial and do the fit assessment. And once the fit assessment is over, you can modify the fit either empirically or proceed with the second trial lens and finalize your prescription. So in pre-fitting evaluation, slit lamp examination is a must. You need to check the lids, you need to check the cornea, conjunctiva, tear film, how much of debris is there in the tears. Do your tear function test, your TPUTs. So all these are very, very important. These are basics, and I would not really go into the details of it. If you have a keratometer, make sure it is well calibrated, because based on these keratometry readings, you're going to decide on the contact lens parameters. So frequently, maybe every 3 months, every 6 months, calibrate the keratometer. I've seen that many people use keratometer, but they don't understand or they don't know how to calibrate the instrument. So that should not be the case. Or if you have corneal topography, make sure you get into the habit of capturing good topography maps and again calibrate the instrument every 6 months. HVID in pupil would help you to determine the initial diameter of the RGP lens and the optic zone diameter, and ocular plane refraction would give you an idea about what should be the power. So one screenshot of how to proceed base curve is dependent on the flat K whenever we are talking about corneal RGPs. See, although I did say in the beginning of my presentation that this will be covering all the RGP contact lenses, whether it is corneal or scleral or ortho K, right? But some of these slides are limited to corneal RGPs because that is where we make a start. That is where we begin our RGP contact lens practice. So if it is going to be a corneal RGP, then the base curve is got by the flat K reading, okay? And you go slightly steeper than the flat K reading when there is astigmatism. How much steeper? I'll tell you in the subsequent slides. Total diameter is got by the formula HVID -2. Please remember, these are the starting parameters and they would change as you see the fitting on the slit lamp. Optic zone diameter could be pupil diameter plus 1.2 or 1.5 millimeters, because we want the optic zone to cover pupil from all 360 degrees. And corneal plane refraction would give you the power of the RGP contact lens. So you need to, I mean, this is my method. I go 1/3 steeper for 1/3 steeper than the flat K when it comes to astigmatism. So if you have 1 diopter of astigmatism, I would go 0.33 diopter steeper than the flat K. If you have 3 diopters of astigmatism, I would go 1 diopter steeper than the flat K. But of course, if you have access to toric RGPs, then 3 diopter astigmatism would need a toric RGP. But this is my rule of thumb. And the rule of thumb would differ from books to books, but almost it'll be close. If you see the bottom picture, this was a toric scleral contact lens fitting that we were attempting. So first is the base curve, the central fit of the lens. This is very, very important. This is where we begin, and then we go towards the periphery. So the ideal fluorescein pattern would differ depending on what kind of lens you're fitting, whether it's a corneal RGP or it's an ortho K lens or it's a scleral contact lens. So in a corneal RGP, we would like to see an alignment fit. If it is the orthokeratology lens, then we need to see the bullseye kind of fluorescein pattern. And if it's a scleral contact lens, then we need to see a vaulting of about 200 to 250 microns. But one thing is very sure, if there is too much of pooling in the center, then we need to flatten the base curve. If there is too much of bearing in the center, then we need to steepen the base curve. So we should be familiar with the term pooling and bearing. Pooling is when you have excess fluorescein in the center, as seen in the picture, or bearing is in a dark area where you don't see fluorescein at all. So the rule of thumb here is 0.05 millimeter change in the back optic zone radius is equivalent to 0.25 diopter change in the power. So if you're making a change in the base curve, let's see the example given at the bottom. You have a patient wherein the vision is good, but the base curve appears to be steeper, so you need to flatten. Now, when the base curve is steep, you have excess fluorescein here, which means you've got excess of positive tear lens, right? So when you flatten the base curve, the positivity of the tear lens reduces and it becomes more myopic. So what is the correlation? If you flatten it by one step, then you need to add a plus 0.25 to the power, because you need to reduce the minus power also. And that is, it's very easy for us to remember by the acronyms FAP and SAM rule, or SAM and FAP rule. So flat, add plus. So if you're going flatter on the base curve, you add plus power to the power. And if you're going steeper on the base curve, then you add minus power to your contact lens prescription. Okay. Diameter, I told you the initial selection of diameter depends upon the HVID. So HVID minus 2 millimeters or minus 2.5 millimeters, as some books would say. But this has to be eventually modified based on the dynamic fitting of the contact lens on the patient's cornea. So if the lens is lagging down with every blink, the lens goes up but falls down completely, and it is decentered, inferiorly decentered, then you might want to increase the diameter so that the upper lid could hold the edge and pick it up, right? So fitting by the Cobb technique or lid attachment technique. If the lens is riding too high, you need to release it from the lid by reducing the diameter. So depending on your HVID, depending on the power, depending on how thick the lens is at the edge, you might want to increase or decrease the diameter. And please remember, changing of the diameter has maximum effect on the fit. So the rule of thumb here is 0.5 millimeter increase in the diameter is equivalent to 0.05 millimeters increase in the base curve radius to get the same fluorescein pattern. So sometimes, you're happy with the fit, but the diameter is small and you want to increase it, or the diameter is too large and you want to reduce it because you don't want the limbal stem cells to get disturbed. So when you're reducing the diameter, you're making the lens fit flatter. So corresponding change has to be done in the base curve radius. So if the lens has become flatter and you want to steepen the base curve radius, so you'll have to reduce 0.05 millimeter in the base curve radius. Edge lift should be about 0.5 millimeters of nice 360 degrees band. It should not be too dark. If it is too dark, we know it's flat. If it is too light, or if it is showing bearing in the periphery, we know that the edge lift is non-existent, right? So it should be optimum. Now, what is optimum? I would suggest you go onto the internet and find out what are the fluorescein patterns edge related, and which is optimum, which is one diopter flat, which is two diopter flat. You can easily get all these pictures on the net. So either you do that, or you order a lens, maybe 3 lenses for a patient, optimum edge lift, then one diopter flatter edge lift, and two diopters flatter edge lift, and see for yourself. Now, if the edge lift is not proper, it affects the comfort, it affects the 3 and 9 o'clock staining, then tear exchange and centration. So we start with the corneal plane refraction. So corneal plane refraction basically gives you just the idea about what kind of power the lens should have. But frequently we have trial lenses in varying powers, and most often they are in -3s and -5s. So you put the lens in the patient's eye, do a quick over refraction, and if there is a little bit of cylinder, then you can do a spherical equivalent calculation. Or if there is too much of cylinder, then we know we need a bitoric lens. So based on your original fitting power of the lens and your over refraction, you can calculate what should be the final prescription. Make sure if the power is in excess of 4 diopters, then you use vertex distance calculation. So some tips to tell you about Lens insertion. Now, there are people who just wash the contact lens and put the lens in the patient's eye. Now, that should not be done. You need to chat with the patient. You need to make the patient at ease so the patient doesn't realize when the lens goes in the eye, because people are apprehensive of putting something that is rigid. Now, that is one reason why these days RGP contact lenses are known as GP lenses. We have deleted the name rigid because the moment you say, I'm going to put a rigid lens in your eye, the patient is so worried about rigid lens harming the cornea, right? So, help the patient relax, talk about what the patient does or what the patient is studying, talk about how this lens is going to help the patient see more clearly from tomorrow. I distinctly remember the first injection that I took. I mean, since the time I could remember, my doctor was asking me, what class I study in and what subject I like. And I knew he was just trying to distract me from the pain of the injection. So similar things that we need to use when we are putting the lens in the patient's eye. Whether we should use topical anesthetic or not is a debatable topic, but personally, I mean, this is the first time I'm admitting on an open forum that I use topical anesthetic, and I've seen that the patient acceptance of RGP contact lens becomes much more better when we use the topical anesthetic, because it is the first impression, which is very important, which decides whether the patient would want to continue on these lenses or not. And the GPLI Institute also advocates using of topical anesthetic, but there are some practitioners who say that it is better for the patient to feel the lens in the eye and understand how the original lens, which comes designed from the lab, is going to feel in the eye. Because sometimes the patient says, when you tried the contact lens on my eye, it was very comfortable because you've used a topical anesthetic. But when the lens becomes ready, the patient says, this lens is not good because I can feel it in the eye. So it's your call. Personally, I prefer to use topical anesthetic, and during the course of the trial, if the trial extends beyond 30 minutes, then the effect of topical anesthetic has worn off and the patient is accepting the lens more readily. Encourage the patient to look down when you put the lens first, because of course after putting the lens in the eye, because when the patient looks down, the upper edge of the contact lens and the lower lid, they don't interact as much. So if the patient is looking straight, then the edge is hitting against the lid. But if the patient is looking down, then we eliminate the touch of the upper edge and the upper lid. Thereby, the adaptation is faster. Give some interesting reading material, because if the reading material is interesting, then the patient is concentrating all his or her thoughts in the reading material rather than how the lens feels in the eye. Okay. Allow settling time. Now, how much of settling time? Make the patient read till the reflex tearing subsides, because that will then help you to assess the fit properly. There is an exception here. If you're into orthokeratology practice, make sure the patient doesn't settle with the lens, because by then the corneal flattening would have taken place and your second trial would go haywire. So that you have to assess instantly. Fit assessment, two steps: the static fitting and the dynamic fitting. Static fitting is when the lens is centered. If the lens is not centered, you can push the lens up, bring it to the center, and then see how the lens is fitting on the cornea. So see where the bearing areas are, see where the pulling areas are, and whether you would like to modify it. In dynamic, see the movement of the contact lens, whether it is rocky, whether it is smooth, whether it goes slightly up with the blink and then comes down and settles at the proper position. Okay, so these are the dynamic fitting assessments. And subjective acceptance is very important, because the patient has to accept you as a practitioner and the lens going in the patient's eye. And I've realized that it has got a lot to depend on your eye care practitioner's confidence and how the patient sounds positive. So if the eye care practitioner, the optometrist or ophthalmologist is very confident about fitting RGPs, the patients can feel it and the patients are at ease. Okay. So ideal corneal GP fit looks like the lens is almost centered and there is an alignment fit. Alignment fit goes to say that there is no excessive pulling anywhere and there is no excessive bearing area. So it has to be an alignment fit. A 1 to 2 millimeter movement is considered to be normal. If the lid is attaching itself to the lens, then the fit feels more comfortable. So some people prefer to do that. Some people prefer not to have a lid attachment. These are individual preferences. Then you do over refraction to get a clear endpoint refraction. The refraction should not fluctuate. Okay. And if it is required, you can modify the fit by conducting a second trial, or if you're very thorough with your rules of thumb, then you know, okay, 0.25, I need to reduce the power, so what I should do to the fit, or if I need to reduce the diameter by zero point 0.5 millimeters, then how I can maintain the same fit and have a smaller diameter. So if you're familiar with the rule of thumb, then you can straight away do the calculations and order the lens, or you can select a smaller lens and conduct a second trial. You need to remember, or we need to remember, that only if the fluorescein is in excess of 20 microns, it will fluoresce. Because sometimes we feel that there is a bearing area, but then it doesn't stain. The patient is comfortable and the cornea is fine. There is no insult to the cornea because there is fluorescein, but it is less than 20 microns. So only beyond 20 microns, you'll be able to see the fluorescein, otherwise you cannot. And if the lens is actually hitting on the corneal epithelium, then you have some kind of corneal insult. Most often these lenses float on the tears, so very rarely you have any corneal issues. But if you do, you can always modify the fit and allow more fluorescein to be there in that area. We start with the center. I think we've covered that. I don't know why I've put it here again. So pooling, we know the fit is steep. Bearing, we know the fit is flat. Mid periphery is mostly bearing because that is where the lens lands on the cornea, right? Edge lift, 0.5 millimeter wide band with a uniform pooling 360 degrees. And ensure your exchange is taking place. This is very, very important. So how I do this is, when you instill fluorescein in the eye, when you finish seeing the fluorescein pattern of the contact lens fit, then you chit chat with the patient for some time, you talk about how the fit was, and then after that, again, go back to your slit lamp examination. So after maybe 30 seconds or 1 minute or 2 minutes, the fluorescein should have completely washed off. So after 2 minutes also, if you're seeing fluorescein, which means the tear exchange is not taking place, and you need to do something about the edge. Final outcome, clear and stable vision, a comfortable lens, and normal appearance. Why I've put normal appearance here is, frequently when you fit corneal RGPs to a patient, they have something called as the contact lens salute. So their neck is tilted at the back. I'm not able to do that because of my spondylitis, but they would often see like this, because by doing this, by tilting the neck at the back and by looking down, they are eliminating the lid and lens touch. So this is called as a contact lens salute, which is more pronounced on day one, and it often disappears in 4 or 5 days time. And definitely there should be no corneal insult, no staining, nothing. So these are some of the secrets which I got from the RGP Lens Institute. So if you can take a screenshot of it and put it on your notice board, it'll be very useful. So for you to see the change in the fit, you need to modify the overall diameter optic zone or optic zone diameter by at least 0.3 millimeters. You need to change the base curve back optic zone radius at least by 0.5 millimeters. I think this should be 0.05 millimeters. I think I made a mistake in typing this. Let me confirm it. No, it says 0.5, but I think it should be 0.05 millimeters. Change the center thickness. We rarely do this, but if at all you are going to change the center thickness, change it at least by 0.03 millimeters. And change the peripheral curve radius by at least 1 millimeters and peripheral curve width by at least 0.2 millimeters. So, and only if you do these minimum changes, then you will be able to see a perceptible change in the fit. You should also know what parameter change would affect the fit most. So if your back optic zone radius, if you change it by 0.05 millimeters, and if there is an X amount of change, then if you change the total diameter by 0.1 millimeters, there is a 4.5x change. So there is a more pronounced change by changing the total diameter rather than changing the back optic zone radius. And if you change the thickness by 0.01 millimeters, then there is a 1.5x change. So depending upon what parameter you want to change, your fit fit would change that much. So if you change the total diameter, the fitting change would be more perceptible. And if you change the back optic zone radius by one step, then it may not show so much. Dispensing visit instructions, no contact lens trial, no contact lens patient is completely done without proper and adequate dispensing visit instructions, and more so when it comes to specialty lenses and rigid lenses. Be patient. You have to be patient and the patient has to be patient. because it takes some amount of time to gain the expertise. Now, this is a new lens. The patient is not used to wearing the contact lens, so it takes some time. Be patient. What I've seen is rarely, if people are not able to put the lens in the eye or remove it and they get frustrated, I discontinue the instructions then and there and I call the patient next day. Because there is no point when the patient has lost interest in putting the lens in the eye, or the lens is just not going inside and it is falling down frequently. There is no point in continuing your dispensing visit instructions, right? So you call the patient next day, start afresh. The patient is fresh, you're fresh, it's another day and it works. So encourage removal first. That is what I do. So when we have finished conducting the trial in the consulting room and we are happy with the fit, the lens is already there in the eye. The patient would wash their hands, wipe them dry, and we keep a nice towel in the area where the patient is going to try on lenses. And why I'm saying encourage removal first is because removal is very, very important. We don't want the patient calling at 10 o'clock in the night, I'm not able to remove the contact lens. So removal is very important and removal is relatively easy. So you can have a two-finger method or you can have a one-finger method. And the moment the lens pops out, the patient says, wow, this is so easy, I can do this. So that gives a tremendous boost to his or her confidence. And obviously suggest the right lens care system. So it should have a surfactant cleaner, a soaking solution, a cleaning solution, or all built into one. You can prescribe a protein remover, you can prescribe a lubricating drop, whatever you wish. So follow up, make sure you call them the next day because you need to understand how the experience was with the contact lens. You don't want the patient to give up so easily in case of the patient could not wear the lens, right? So call them the next day and sound positive, be energetic, just as the cartoon on the slide says, and ask them to visit the clinic after 1 week of wear. And the patient has to be wearing the lens from morning to afternoon or evening so that you understand if the lens is causing any problems in the eyes or if the eyes are completely normal. And that time also you need to reinforce why you have chosen RGPs over soft contact lenses because they need to understand again and again that these are the only lenses that will work for their requirement. I have seen in my practice that this also helps, especially with respect to my myopia control patients. So, patients who are very happy with your services, I often ask them, is it okay if I share your telephone number with a potential patient of mine in case if they have any questions? I mean, I do answer those questions, but if these questions are answered by another parent whose daughter or whose son is already on these lenses, then it becomes easier for the new patients to accept this new lens, right? So there are some people who are more than happy to counsel the new patients for you. So of course, I take their permission before I share their telephone numbers or email IDs. And I often give them printed materials welcoming them to the practice and why these lenses are special and why my practice is special. So that helps to build up confidence in my practice and in me as a contact lens practitioner. I can even, I frequently do this. People don't like their patients going on Google, but I am one person who would take my letterpad and write down few sites and make them visit these sites to read up about the positives of these lenses and negatives about these lenses. So when they come to you next time, they have so many questions for you and you can answer them confidently. You can keep about studies of RGP contact lenses handy. So this helps in counseling the patient better. So future advancements, I think I'm overshooting time, so I will like to go a little faster here. This little instrument changed the way I practice specialty contact lenses forever. I've got no commercial interest. There are various brands available, but world over, if you ask a specialty contact lens practitioner, this is the instrument to go with. So it gives us better understanding of cornea because we are checking the cornea over 1 lakh points, right? Rather than checking the cornea only on central 3 millimeters. So because of this assessment, I can get a much better peripheral fitting because it generates the steeper E values and flatter E values. So I can decide whether I need toric peripheries or I need spherical peripheries. If I need toric, how much toric I should go. So I can practically get an alignment fit on a toric cornea because of this instrument. There are built-in softwares of the topographer itself, and there are various brands of contact lenses. They have included their software in the instrument. So I can just get a drop down and select what brand of lens I would like to order, click on that brand, and it gives me a simulated fluorescein pattern image. So this instrument helps you greatly in fitting your corneal RGPs, your scleral contact lenses, your multifocals, and orthokeratology lenses. It's an amazing instrument. So if you see these pictures, this was done as an experiment in my clinic. The top picture shows you a stimulated pattern of rose K fitting on a keratoconic cornea. And the bottom picture shows you the actual fit. The fit is not great. Don't go by the fit, but just look at the comparison. It gives you a fair understanding about how you can expect the fluorescein pattern to be. It's an amazing thing. So you have standalone softwares if you don't want to purchase a corneal topographer, but you want to use the standalone softwares. You have the RGP designer, you have the Wave software, OrthoTool, iSpace, and I'm sure there would be many more which I'm not aware of. So software-based lens designing, you can design all these contact lenses, the custom ortho K, hyperopic ortho K, presbyopic ortho K, and daytime myopia control lens. So you get all the curvatures as shown in the image in great detail. Just give the sheet to the lab and they can make the lens for you. Sorry, it should not be hyperopic ortho K. It should just be hyperopic patient, not ortho K. You can design your bitoric RGPs. So based on softwares included with the instrument or standalone softwares, you can get curvatures and powers and the peripheral curves, all these details. Just give it to the lab, they duplicate the lens and the lens fits so well. And you can also modify the peripheral curvatures or the base curve or the total diameter and immediately see how the fluorescein pattern changes. So if you're happy with the fluorescein pattern, the virtual fluorescein pattern, then you know these parameters are right and most often you get it bang on. So this is the Wave software. And we are at the last slides of my presentation, and I thought I would put this very interesting picture. I would not tell you anything about it, but can you guess what kind of fit this is? So Fakhruddin, I think I'll just give about 30 seconds for people to type out their responses on the chat box. Oops, sorry.
Yes, we can do that, sir. I think
Yeah.
30 seconds should be good. And yeah.
Because this is one of the very least seen fluorescein pattern, and when I was hunting around for my pictures, I came across this and I said, this is going to be interesting. Let's see how many people can pick out what kind of lens this is.
Yeah. So anybody?
Let me try and zoom it for you.
Yeah.
So we know it's a corneal lens. That much hint I'll give you. So can you comment on the fit?
Okay. So let's just see. There's a picture on the slide, and if you can just try a wild guess and let us know what it is about. So we have received a couple of replies here. They are saying steep fit, probably because of the appearance of the pooling, the greenery in the center.
Okay, okay.
Yeah.
So, okay, I think I'll give the answer. It's an hyperopic ortho K fit. So this was fitted by Dr. Nitesh Barot, who was one of the excellent ortho K lens designers. And this patient was fitted in my practice. And one night he knocked off a good amount of cylinder in all the hyperopic power. I think it was around +3 or +4. And the patient could read 6.6 next morning. So how to get started, couple of slides and then we finish. I think I've already said this, be an observer. Without observing, you cannot learn RGP contact lens fitting. So visit any specialty practice. I did mention for a week, but I think 1 week is less. If you can spend 6 months, nothing like it, but whatever maximum you can. Learn about patient counseling, fitting protocols, learn how to read the fluorescein patterns and lens modification tricks, and make a sheet of all the rule of thumbs and put it on your notice board. So every morning you read through all that and try these lenses on your friends and relatives. That is enough to get you confidence. Now, I frequently get calls saying that corneal topographers are quite expensive and we really cannot afford it. Well, I cannot afford it. It's very expensive. So what do you do if you wish to have a corneal topographer? Don't buy one. Refer the patients for topography. I mean, there are so many ophthalmologists in your area. Refer the patients to them. Build the topography examination fees and your consultation fees. That serves two purposes. It saves you a lot of money in buying corneal topographer. And when you're referring this patient to a cornea clinic who has a good quality topographer, that ophthalmologist also realizes what kind of practice you're having and you get more referrals. The alternatives could be you pull in funds and you buy topographer. So 10 practitioners can come together and have a common topographer. Similar thing you can do for the trial sets, because some trial sets could be expensive. I know I have few trial sets which are costing 4.5 lakhs and 5 lakhs also, one trial set. Now, start with a corneal RGP set. This is very economical, so every individual practice can have one set. You could go in for keratoconus trial sets, which again are not very expensive. They are expensive, but not so much. You can easily afford to buy them. And yeah, that's it. So how do you announce that you're doing fitting of these lenses? You connect with the ophthalmologist. For soft contact lenses, patients come to us. We are the first contact for them. But for complicated corneas, I'm sure the patients would go to eye hospitals and ophthalmologists first. So unless the ophthalmologist and eye hospitals know that you're into fitting specialty lenses, how can they refer the patients to you? So make sure you tell them, you make brochures, you give it to the patients, you give it to the ophthalmologist and eye hospitals, and ask for referrals. You connect with Facebook and WhatsApp group of specialty contact lens practitioners. So every case, whether it is keratoconus, PMD, dry eyes, they have their own groups. Somehow gain entry into those groups and announce that you're doing these fittings. Write articles in the newspapers. That's a very nice way of your patients knowing that you have a specialty contact lens practice. And I used to keep large diameter scleral contact lens on my patient on my table, and I used to show these lenses to all patients. So whether they need it or not, the moment they see that large diameter scleral lens, 23 millimeters, 24 millimeters, they are like, "Wow, what kind of lenses are these?" And they automatically understand that you're a specialty practitioner. And in fact, to be very honest, I used to show these lenses even when I was not fitting scleral contact lenses. But these patients used to go outside and talk to other patients saying that, you want contact lenses, that's a specialty center, go to that center. So this is where it all ends. I know it was a very long presentation on a Sunday morning, but I hope I could share few tips with you which will be useful for you to implement in your practices if you're already into specialty lens practice. And these help those optometrists who are not yet started specialty practice to at least consider starting one. Because right now itself, Fakhruddin, the situation in India is such that the contact lens sales, the regular soft contact lens sales are dropping, and the specialty lens sales are increasing. I should not call it sales, but the specialty patients are increasing. So this is the right time. If you're not into it, get into it. If you're already into it, make sure you go higher and higher. So that brings us to the end of today's talk, and I would be happy to answer a few questions if you have. And over to you, Fakhruddin.
Okay, so thank you so much, sir. I think really nicely presented. So while waiting for some questions, just one thought. I think you did mention about this as well. This is the time where you said that you use probably the anesthetics in terms of fitting RGP lenses, and you did mention that it's a practitioner's choice. Of course, it's not that you have to do, or it's a compulsory thing. But would you do it for all patients, or you judge it by individualized base? Like you think that this patient is watering a lot and then you do it, or you would ideally do it for all?
Okay, good question. So for all the ortho fits, it's a must. It's a compulsion. Okay, because you cannot put the ortho lens in the patient's eye and wait till the reflex tearing subsides and then assess the fit, because by then some amount of correction would have taken place. So ortho all cases by default, it has to be there, right? Earlier, I used to be selective in using the drops. And as I said earlier, today is the first time I'm admitting on an open forum that nowadays I've started using Paracaine for all the patients. Because the first impression is, okay, the patient says, I can tolerate this. And after about 30 minutes, when the effect wears off and your contact lens trial is still continuing, you can actually observe how the patient is willing to accept this. So it becomes easier. I mean, this is my personal experience. Though, as I said, the RGPLI Institute recommends using of topical anesthetic, whereas the IACL modules, because we as students of contact lenses, we study IACL modules so much, they dissuade you from using the topical anesthetic because they like the real life scenario. They want to give that experience to the patient, how the lens will feel in the eye. So both sides are correct. I cannot really take one side, but these are individual preferences. So you go by what works for you.
That's right. Yeah. And I think very important point, it reduces the chair time for you as well as a practitioner. And yeah, in ortho care, yes, you don't want the cornea to change while the patient is getting adapted. You did mention that as well. So again, really important point there.
So Fakhruddin, for people who have said that it was a steep fit in the RGP, I would give them a good thumbs up because yes, that is how a steep fit looks like. And I don't, I did not expect anyone to answer that because we rarely think about hyperopic ortho.
Yeah.
But
Yeah.
yes, hyperopic ortho is there, and these patients are very happy to get rid of their hyperopic prescription.
That's right. So it's totally opposite. Whereas in myopic
Yeah,
orthopedy, we need center flattening. In hyperopic, we
just
need center steepening. So you're building up the epithelium in the center.
yeah.
Right? Yeah. All right. So one question here is any experience on, do you want to suggest picky bag systems for any patients or any conditions? Any
No,
thoughts?
a big no. Why do you want to suggest piggyback when you've got excellent designs of mini sclerals and scleral contact lenses? You actually got corneosclerals, mini sclerals, and full sclerals, and you have the impression made sclerals also. So you've got a wide range of scleral contact lenses which work beautifully. So why do you want to suggest a piggyback system? If at all you want to go with combinations of RGP and soft, then why not a hybrid contact lens? Although that also I would really not like to get into because one, it's very expensive for the patient, and two, because we've got excellent scleral lenses available. So I never really got into fitting of hybrid lenses. But piggyback is no, avoid.
Why? Is it because of
Imagine you have to clean four lenses, you have to maintain four lenses, and you have hybrid contact lenses. Why not use them?
Yeah, I was just about to say that is it because of the care and maintenance? We already have a non-compliant patient. The compliance rate is anyways not that great with one lens for each eye. And if you
Yeah,
have two lenses, it's going to be a challenge. And very, I think nowadays the hybrid lenses are so nicely available and scleral lenses, for example, they can do the job. Why you want them to have two
definitely.
lenses in the eye, right? Yeah. So one question is here, I think it's kind of a case analysis kind of a question. Recently, the attendee fitted an RGP to one patient during a trial fit. Patient was fine and comfortable, but after insertion of the ordered lens, patient can't bear the lens for more than an hour. She is looking only in the down gaze. What could be the reason? So we are assuming that the parameters were same here in terms of trial lens fitting and the new lens. So anything which you would like to comment on this, sir?
Yeah, see, the first thing that I would like to suggest is make sure you're using the same lab's trial set when you're ordering. Let's say you're ordering a lens from lab A. Your trial set also should belong to lab A. Frequently, I've seen that lab A gives a complimentary trial set that we keep, and lab B gives us lenses at economical prices, and we want to use the lab A's trial set and order lens from lab B. That doesn't work because every lab has got their own peripheral curves and their own peripheral lens design. So I assume that she would have used the same lab set. Now, having said that, it has got a lot to do with the peripheral fit. So make sure your peripheral fits are good. And sometimes, I'm not saying all the times, but sometimes the final lens that comes from the lab has got warped. The lens is warped. The BC is warped. So check that if that is the case. And I don't know if I should reveal this, but many a times what happens is you have given parameters to the lab and they already have a lens reject which is matching very closely but not 100%. So they end up sending that lens rather than making one fresh one for this. This is a very common practice, although it's a very secret of many labs. But you assess the fit. If the fit is fine, then maybe you want to send the lens back to the lab to refinish the edges. Because if the edge is not properly finished, then that also can be a source of discomfort for the patient. But these are only things that we can think of. Actually, till you see the fit, you really cannot determine what could be wrong.
That's right. Yeah. And again, I think a very important emphasis you made, sir, in terms of the trial lens set. So if you are planning to fit a particular design A, you have to order through that design A manufacturer. And I think that's a very common problem we have. There are so many manufacturers as well. So we tend to have only one trial lens set, but we order from variety of people looking at the amounts, and then we
Yeah,
think that it will work the same, but it's not like a soft lens. Even for soft
yeah,
lens it doesn't work, but
yeah.
you have to make sure that you are doing that.
Soft lens actually is more forgiving. You can make some mistake and the soft lens will not complain. But RGP lens, you make one mistake and the RGP lens or the patient complains.
That's right, yeah. And let's look at one more question. Let me just put that on. So when it comes to the use of normal or keratoconic RGP in case of early keratoconus, how is your experience when it comes to suggesting lenses? For example, because of the financial factor, which is important, and also because of the availability of these lenses. So how do you probably go in counseling your patients, and what are the key points you would like to give us here?
First thing is stop believing that RGP contact lens or keratoconus contact lenses are expensive. I think this has got, this is more in our head rather than in the patient's mind. So first get rid of that thought. When a condition demands a specialty lens, it has to be suggested. Don't be scared about it. I mean, come on, when you have a heart attack and the doctor says, bypass has to be done and you have to spend 2.5 lakhs, nobody thinks whether 2.5 lakhs is economical or expensive. It has to be done. There is no option. Now, if I understand the question right, the participant is asking whether I would like to go in for a specialty lens right away or go in for more budgeted lenses which can work in early stages of keratoconus.
Mm.
Well, why not? If the simple methods are working, if why contact lens? Even if your spectacle is working for early keratoconus, why not give that? If the vision is good, give it. But make sure you check the binocular status also, because frequently it is seen in various studies that it is the aberrations which really bother the keratoconic patient. Although the vision is 6 by 6, the patient keeps complaining, the vision is not very clear. If that is the case, then you move to specialty lenses. But if the patient is subjectively happy with the vision, let him be happy either with your spectacles or spherical soft contact lens or toric soft contact lens, and then move on to specialty eventually.
Yeah.
I hope that answers the question.
Yeah, and I think once you put in these lenses, once they enjoy the vision quality, the financial and the cost factor is something which you can
Yes.
discuss, and it's probably should be the last thing to be considered. As you said, it's just in our head. We should keep that aside for a while and give the best to our patients, right?
See, when you go to a physician, when you're suffering from fever, you go to the physician. The physician never says, this antibiotic is costing 100 rupees, this is costing 150, and this one is costing 250.
Yeah,
No, he says, this is good, this is what you have to take.
yeah, that's right. So he is
And
the one
let,
who's
let the
deciding.
patient let the patient say this is expensive for me. Then you think about how to get him help or how to give him the second best. But why do you want to assume for the patient that these lenses are expensive? It is not.
Okay, that's right. A couple of more questions here. Any experience on Marfan's syndrome? Would you prefer them to fit with RGB or soft lens? Any comments on that if you have fitted them?
Well, incidentally, because some educators are also attending today's presentation and most of them are students, and I believe that most of us would be using the IACL website and IACL resources. So one of the first cases that went from India into IACL resources was a Marfan syndrome case from my practice. It is case number 11, if I remember it right. And that was even suggested that this is one case which has got the longest follow-up. I think today it must be about 20, 22 years I'm following up this patient. And this patient earlier was on RGP contact lens, and later on we shifted him to soft. But there is no preference as such. We shifted him to soft because the patient then started working somewhere and had to travel a lot of distance and was getting troubled by the RGP contact lens. But it's anybody's choice. I mean, there is no clear-cut demarcation that in Marfan syndrome RGP should work or soft contact lenses should work. It depends upon how much of lens subluxation is there. So if the lens is really subluxating and the RGP contact lens edge is coming in the new pupil, then that might trouble the patient, and a soft contact lens would be more stable. So it depends upon so many parameters.
Okay, okay. So we must also look at the
Case
uh,
to case, it depends.
case to case. Yeah, yeah, yeah. Okay. One more here is which one is better? Again, this is kind of a personal question. Which one do you prefer, hybrid or sclerals? Which one is the best?
Sclerals for the simple reason that I don't have much experience with hybrids. So I would say sclerals. I'm very happy with sclerals.
Okay, all right. Uh, Sclerals, I think nowadays sclerals are also doing a comeback like the RGPs, right, sir? Sclerals is
Yes,
now
yes, yes.
taking over the market.
Sclerals have already made a huge comeback, huge comeback.
Yeah. And it's not only for complicated corneas and all that, but for dry eye management, and it serves well for a lot of things actually.
Yeah, Fakhruddin, I would just like to address this question again. Just to be fair for the hybrid contact lens, that's also an excellent option. So if you have hybrid contact lenses available and they're working well for you, they are a good option. But I prefer sclerals for the simple reason that I've got a huge inventory of scleral contact lenses and I've not really tried hybrid.
All right. Okay. Yeah, that makes sense. I mean, in terms of experience, you have more experience fitting sclerals.
Yeah, because hybrids are expensive. I think they have to be used as frequent replacement lenses, and sclerals would last you for what, 3 years, 4 years, whatever.
That's right. Okay. One question more is how to avoid dropouts. I think some classic points you have already covered, but maybe if you can tell us on how to avoid dropouts, as the attendee says that in his 10 years of RGP practice, very few patients come back again for new lens, and because even though they are happy with the lenses and have good vision. So any tips here which you would let us know on how to get patients back?
See, there is one problem with RGP practice. These patients frequently mingle with their friends who are onto soft contact lens, and they automatically think, it's a soft lens, so it's going to be more comfortable. It's a soft lens, so it's going to be more safer for my eyes. So that is one of the reasons why, which makes the successful RGP wearer, even 20-year-old patient, I mean 20 years of RGP wear patient, to move on to soft. But every visit, every follow-up visit, if you stress the importance of RGP materials, if you tell them that these lenses will have least percentage of complications, these lenses would be economical, the deposits don't really bother you so much. If you keep stressing on the advantages of RGP, there are so many of my RGP patients, sometimes even if I offered them a soft contact lens, they say we are happy with a RGP contact lens. And with respect to patients not coming back to your practice, have a good feedback system. Call them every maybe 6 months or a year that they haven't come for a follow-up. Give them some incentive to come to your clinic for a follow-up. And during your follow-up and face-to-face meeting, you can chit chat with the patient and reinforce their faith in RGPs.
Yeah, and I think patient's education, explaining, I think you did cover a lot in the beginning as well. When you said that I'll only fit the patient if the patient is ready. So communication skills is really very important. Yeah. And let me just have a look. I think, yeah, we have taken up almost all questions, sir. Thank you so much in terms of taking up the session and giving us your inputs on this particular topic, sir.
Thank you, Fakhruddin. Thank you for having me. And thank you all for all the attendees who spent their Sunday morning and afternoon. I think it must be afternoon there in Malaysia, listening to this talk. Thank you very much.
Yes, thank you so much, sir. Once again, from the entire team OOLS. We do have sessions planned next week, and just a reminder that we have the 100th session next weekend, and we are looking forward to receive some feedbacks either in the video or a text message. And you can send us any of the feedbacks to us, and we will compile it in a huge video for us to look at when we finish the 100th session next week. Thank you everyone for attending today's session. Thank you, sir, once again for giving us your time on Sunday. To the attendees, I will see you all again next weekend. Take care, be safe, and bye-bye.
Fakhruddin, very professionally managed, very nice. Really enjoyed being here.
Thank you. Thank you so much, sir. Thank you so much.
Okay, enjoy rest of the Sunday. Bye
You
bye.
too, sir. See you. Yeah.